Welcome everyone back to the second part of our SOC inaugural session today. We're very excited. We're going to be focusing on this session with a very nice and talented group of speakers, and we'll be talking about education and training the critical care cardiologists. My name is Carlos Alviar. I'm a critical care cardiologist at NYU and director of the CCU and ECMO program. Very honored to have these panelists with me today. I'm going to have them introduce themselves, and then we're going to jump right into the debates. Eric?
I'm Eric Hall. I'm a current cardiology fellow and future critical care fellow at UT Southwestern in Dallas.
Jason Katz, critical care and advanced heart failure transplant cardiologist at NYU.
Good morning, Dave Dudzinski, critical care cardiologist, Massachusetts General Hospital.
Good morning, Rand Lee, critical care cardiology, advanced heart failure transplant cardiology at Cleveland Clinic.
Hi, I'm Amanda Garfinkel. I'm a third-year cardiology fellow at the Brigham doing critical care cardiology training at NYU next year.
I'm Nina Chen. I am faculty at Duke University pulmonary critical care, so I'm one of the pulmonologists who have infiltrated this conference, and I'm also the critical care program director.
And I'm still Neal Chaisson.
Hi, Sean Van Diepen, cardiologist and intensivist, University of Alberta.
So I just want to say, Nina, you didn't infiltrate. We were very happy to have you here and welcome you because I think it's really that it speaks for the team effort. So let's just start with our debate so we have some really good time for discussion. I want to welcome Neal to the podium and take it from there. Thank you.
Well, first of all, I just want to say thanks to Jason and Balam and the Society of Critical Care Cardiology for inviting me, and to Houston Shock for putting on what I previously described and still believe is a pretty amazing demonstration of expertise. I thought this was going to be like 20 people. Clearly, I underestimated what happens in cardiology. Okay, I need the thing. So what we're going to talk a little bit about today is whether there should be a specialized training pathway for critical care cardiology. So what the path that I was asked to defend was the following: that critical care cardiology requires a dedicated specialized training pathway to meet the unique demands of the cardiovascular intensive care. What I'm going to say before this is what happens when you do slides on an airplane, is that you don't read the email because you don't have access, and I didn't realize that I was supposed to put my disclosures. So I don't have any material disclosures, but I have a couple that are probably worth talking about in this. The first is I'm not a cardiologist. I think I established that. The second is that I recognize I'm at a cardiology conference. I recognize that the person I'm debating is a cardiologist. He's also dedicated his life to extra critical care training, okay? And the final disclosure, which is probably worth saying, is that he was my fellow, okay? Now, there's no expectation of deference or anything, and I will say he was an amazing fellow. I seriously believe that. But the point is that when your fellow and you still work together, you get insights that you don't realize that, like the Miranda rights, are going to be used against you in a debate. And what he disclosed to me at ACC last week was that he wished he had my side of the topic. I'll just remind him of that. Okay, so let's go ahead. So you guys heard a little bit earlier in the last hour about the changes in the CICU landscape. And the first reference I have here is the paper that you guys saw from Jason Katz, which looked at about 30,000 patients at Duke University over the period from 1989 to 2006. And as was eloquently described, there is a true changing CICU landscape from the days of those first CICUs back in the 1960s. Specifically, patients with STEMI are declining in percentage of when represented as a percentage of CICU admissions. In fact, actually, the biggest decline in primary diagnoses was coronary artery disease. The use of MCS should be no surprise to anybody, is rising. And non-cardiac diagnoses, including sepsis, acute kidney injury, and acute respiratory failure, now constitute almost 50% of admissions. And that was back in 2006. I don't know what the data since then has been, but there was a steady, slow upward trajectory, and I think probably to assume that that's still the case is a safe assumption. There's an increase in non-cardiac procedures, things like mechanical ventilation, increasing bronchoscopy, to name a few of them. And the population that you all serve today in a CICU setting is frankly older, more frail, many more comorbidities. These are people who, back in the 1960s, were simply determined to be inoperable or too frail for whatever procedure they were going to get. And we've decided to take care of them today, despite those frailties and comorbidities. As I was looking through the literature, I came across this nice little excerpt from one of the articles from the Journal of Heart and Lung Transplantation. I'll just read it for you. It says, "The complexity of cardiogenic shock admitted to the contemporary cardiac intensive care unit demands a workforce skilled to care for these extracardiac critical illness complications with an appreciation for how cardiac systemic interactions influence critical illness outcomes in afflicted patients." I was like, yeah, I agree. And I couldn't believe it, but this was one of the authors. Unbelievable. How do you defend yourself? Couldn't believe that. So let me just back up a second in a moment of a little bit more seriousness. What are people like Chaisson and Rand Lee and other experts actually saying in these articles? What they're advocating for is that there's things that we see or you see in a modern CICU that are clearly within the scope of the traditional cardiology training program. Things like advanced hemodynamics, MCS, cardiac interventions, complex arrhythmias, things that if I see them in the MICU, I go, hey, I want a cardiologist to help me out with these things. There are other things, though, that are outside of that scope of the traditional cardiology training paradigm, and I've listed those there. Now, I'm not saying that none of those things occurs in a CICU or that you don't have exposure to those things, but I think we would all agree that just because one has managed a patient with that diagnosis does not make them an expert at that, as was eloquently described in the last debate. And so it's a little bit of a faux pas probably to bring up the ABIM in a cardiology conference right now, but I'll go there. And I went back and I looked at the blueprints for critical care medicine and cardiology boards and what the breakdown of that blueprint as far as emphasis is. And as a program director, what I can tell you is that I think a lot about this blueprint because this is how we set our educational curriculum based on this. So if you look at the critical care medicine blueprint on the left and the cardiology blueprint on the right, what you're going to notice is that there's not a ton of overlap, actually, in topics. Cardiovascular diseases comprises just shy of 20% of critical care medicine training. But aside from that, the things that critical care medicine trainees think about and get tested on at the end of the day is a much broader scope and quite different than what the average cardiology training program probably is emphasizing for their board preparation. But I don't want to argue from the theoretical perspective, so what I thought we would do is go back to a little bit of data. And you saw some of this data previously, but I want to sort of repackage it in a simple way. There have been well over 50 studies looking at this concept of high-intensity ICU staffing. We talked a little bit about that in the last hour. And just to define this, this is a well-trodden path in medical ICUs, and I think the debate is essentially over in the medical ICU literature as to whether it improves outcomes. You can see two systematic reviews that I've put here, one by Peter Pronovost and another by Elizabeth Wilcox. The first one back about a little over 20 years ago, the second one about 10 years ago. And they were pretty robust. One had 26 studies, one had 52 studies, and every single one of them, I just put two here, but there have been others, has suggested essentially the same thing, that mortality in hospital and ICU Length of stay, both in hospital and ICU, all went down, okay, and not a little bit. And so there are other benefits, though, to high-intensity staffing in the medical ICU. The models and the analyses and studies have consistently shown that application of evidence-based practices improves, that this model lowers resource consumption. I think your CFOs would like that. It lowers the cost burden of patient care, and it lowers ICU complication rates. Now, it doesn't take somebody with a PhD to say, yeah, that kind of passes the sniff test, right? And the interesting thing is that this doesn't only happen in major academic medical centers. This happens across a variety of populations and hospital settings. So much so that actually the Leapfrog group now endorses this in their recommendations for medical ICUs, and the SCCM guidelines now recommend a high-intensity ICU model as a grade 1B recommendation in their guidelines. So let's bring this back to cardiology critical care. If I was to think about a high-intensity CICU staffing model, I think that has been proposed that you would have an intensivist plus a cardiologist. One of the two of those would be the primary, or they would co-round in the CICU, or a critical care cardiologist as sort of owning both sectors of that. And as I have alluded to, when polled, a majority of CICU directors say this model provides better care. Unfortunately, probably for reasons of just resource allocation and trying to catch up, we really haven't gotten there, and it's still a minority of CICUs which have either one of these staffing models, and I think that's an area where we can move forward. There aren't as many studies in the CICU literature looking at high versus low intensity staffing models, but the few studies that do exist suggest very similar things, and that should be probably no surprise to anybody. There's decreased CICU mortality, in-hospital mortality, decreased length of stay, decreased cost, all themes that I just talked about in the medical ICU. Interestingly, a study by Chaisson looking at integration from an open to a closed ICU system also suggested that there's better multidisciplinary or interdisciplinary communication between other rounders, nurses, APPs, et cetera. And something that I thought was really nice to include is that trainees felt like that model led to a better educational experience, something that I think a lot about. So do all CICUs need a critical care cardiology trained physician? Well, that would be great, except for there's a lot more CICUs than there are critical care cardiology physicians, and there's no good way to get up to speed in a short amount of time. This is a review that just came out in circulation by the American Heart Association, American Heart, and they describe 3 levels of ICU. This nice table that I took some of their pieces from suggests that in a level 1 ICU or CICU those should be where we put our emphasis for critical care cardiologists. And that probably makes sense, right? They're going to have the highest complexity of care. Those patients are routinely going to be going on advanced therapies or go to surgery. There's multiple modalities that need to be used both day and night, like bronchoscopy, CRRT, targeted temperature management, MCS, et cetera. But the level 3 ICU, maybe that's not the place where we want to start. I think one of our prior panelists was talking about it's just not realistic in a small community hospital to have a critical care cardiologist in that setting. But what was interesting is that this review suggested that all 3 levels have a high-intensity training model, and that's what I would advocate for to this community, that we start with as our first goal, and I think that's achievable. Within the debate of how do we train critical care cardiologists, there's a whole host of ways. I could think of many more than were summarized in this review here. Some of those require an extensive amount of training beyond residency. Some of those try to integrate the critical care pathway into a cardiology pathway. I think actually in the next 10 years, it wouldn't be unreasonable that we could probably get to a place where the model for critical care cardiology looks very similar to the model for pulmonary critical care medicine. And I am not a cardiologist. I don't know what you guys do. I know that your board's test is insanely long, so there must be a lot that you learn. But I think that you could probably do it in 3 or 3.5 years without too much problem. So I told you I wrote these slides on the plane except for the last slide. And I was touching these up yesterday. And I was like, how does one come to a conclusion for a 10-minute talk? And they're like a lightning bolt from God. Somebody called me who was a dear friend of mine who's a critical care, or who's a heart failure cardiologist, and she was telling me that her mom had had a out-of-hospital cardiac arrest and that she couldn't meet me for a meeting. And so I said, oh my gosh, like that's terrible. You know, obviously, yeah, don't meet me. Take care of your mom. And I said, you know, I started asking, well, did she go to the main campus? And she said, no, she was at an outlying hospital, but they were working on transferring her. I said, well, if you don't mind me being a little insensitive, why are you transferring your mom to a major tertiary care center? And she said, and I quote, because there's critical care cardiologists there. And I thought, well, I'm just going to drop the mic on that one right there. And thanks to her, fortunately, the good news is her mom is doing better. I did check on that. But I decided to end with this slide. If I were in the hospital and I had a critical care cardiology condition, what would I want? Or what would I want for my loved one? So ideally, I think I'd want a critical care cardiologist. I would want somebody who really knew the ins and outs, not just of the 20% of my body that the heart constitutes, but the entire spectrum of how those things interplay. And I think the data in the medical ICU supports that people who have dedicated intensive care training actually do things that matter. They lower mortality, they decrease length of stay, they lower the cost of care. We communicate better with the other caregivers. And as I said before, the people we're training to try to get us to the next step of this ultimately have a better experience. And I think that's a path worth winning on. So thanks.